Okay, this is so you have heard so much about CVA. I just want to share two case studies. This boy is a premature baby. The first one, it was a premature baby who had a very stormy neonatal period and he is having neonatal convulsions also. He is unable to recognize his mother, no eye contact. You must have seen his face is there is no expression, there is no social smile. So that is low functioning CVA. Now this is sorry previous okay this child play okay mouse this child he is coming from the school who is branded as learning disability. The parents are saying he's clumsy and intelligent but not performing well in the school. So that is their complaint. So when we were doing the assessment, this is Leah puzzles, he was unable to recognize the shape, size and direction. So this becomes very important in studies. So that is also CVA. So at one end of the spectrum, we have a child who cannot see, very low functioning CVA without eye contact and poor visual acuity. Whereas in the other end, we have high functioning CVE with almost good vision, but clumsy and unable to learn. So these two pictures you should keep in mind to understand the spectrum of CVA. Common in all this is eye is normal. The impairment is due to cerebral pathology. Now the definition they have told the CVA is a verifiable visual dysfunction which cannot be attributed to disorders of the anterior visual pathways or any potentially co-occurring ocular impairment. That is latest definition by Saki. And low vision is not a typical feature of CVA. Almost 60 to 70% of children with CVA have visual acuity better than 6 by 18. So in our country also the CVA is increasing. A recent study from Hyderabad, LVP, Dr. Niranjan Pehre and Gordon Dutton, they have shown that under 3 years of age with severe visual impairment, 33% had CVA and 11% had CVA plus OVA. So it is alarmingly increasing. Why we need a special clinic for CVA? Actually, these CVA children, when mentioning about the clinical features, Dr. Samyukta has mentioned, they have a variable vision. The dictum is the vision may vary in different situations. So in the busy OPD, in the visual clutter, their vision will collapse and they may not cooperate also. And we need more time, patience and skill to examine them. And to evaluate them, we require special tools like Leah gratings, hiding ID, etc. And usually they have multiple disabilities and may require special seating arrangements like CP chair and all. So this clutter-free space where you have ample time and relaxed atmosphere is needed for a CVA clinic. Now I just want to share my experience, how we started our clinic. We had started ROP screening in 2015 and was doing this follow-up of premature children, vision assessment and all. And while doing the assessment, once one mother brought her child, around 2 years child, was lying, it's a CP child. She asked me, Doctor, എൻ്റെ മോൾ എന്നെ കാണുന്നുണ്ടാവോ? I was shocked and really didn't know what to answer. And that question haunted me for quite a long time. And maybe I just was thinking how to help these children. And meanwhile, I got an opportunity to attend a national level training on vision assessment and pre-verbal children. That was done by Dr. Leah Hivaran. She's very passionate about CVI, assessment of CVI and training. So from her, I got so many guidance, and like even after the training, we could communicate over mail, and she was very helpful. And slowly we picked up, and I contacted Dr. Dutton also by mail, and he was also very helpful and encouraging. So with these guidances, we started one CVI clinic. It was inaugurated in 2019, maybe the first one in government setup at WNC Palakkad by Sri MB Rajesh, the MP then. Actually, he took keen interest in this project and arranged sponsors, without which we could not happen, because it is not in the government sector. It was the CVI, the concept. Now NHM has taken up this concept, but still we are struggling because of lack of funds. And we were privileged to attend the national training on CVI in 2019, conducted by, organized by NHM, and Dr. Linda Lawrence was the trainer. Dr. Parvati, who attended the training, is here. And another optometrist is our REAC optometrist. Now, the advantages of being in a government multidisciplinary hospital. That is, always NICU support is there. You know, the high risk babies, you know, and they will come to you for assessment. And then always pediatric support is there. And DIC, District Early Intervention Center, as Dr. Sujata mentioned, that is a nodal center. That is the ideal place, because we have all these people there. So you have a physiotherapist, we have a special educator. So vision has a pivotal role, and you can share your information, how much vision the child has, that you can share with the other people, other team members, like physiotherapist. Because if the child is having inferior field defect, he will not be mobile. He will not keep the leg and on the floor because he cannot see. So it's always a teamwork. When to suspect high functioning CVI? We all know low functioning CVI will come to you because he will behave like blind. But in high functioning, they will go to school because they have near normal vision. So when the child has difficulty in reading, writing, and basic arithmetic, and when the child appears to be clumsy, when the child has short attention plan, then problems symptomatic of lower field defects, such as difficulty in climbing the stairs, and some children will not like crowded places like that. So in such situation, you should rule out high functioning CVA, like in learning disability. Some from school, people will come, will be referred as learning disability. See, their intelligence may be normal, but they cannot recognize shape, size, etc. And that may be the reason for their poor performance in the class. And this Dr. Samyukta has mentioned everything, behaviors typical to children with CVI. So I am not going into the details. A child with CVI, like in low functioning CVI, the child may become aware only when surrounded by a tent with nothing else to see. That situation is very tricky, because child will behave like a blind child. And another concept is looming. Fast moving things may not be seen, or may appear to be on collision course when actually they are not. And the child may scream and will get frightened with no reason. And the parents will be alarmed. They'll be wondering why the child is behaving like this. And another important thing is eye contact may be abnormal. So in the school, the teacher may say, see, look straight, like that the teacher will say. And the child cannot look up and say the answer. Both together, he cannot say. So what we train the child is, we tell them that you just look up and then turn your face and then answer. That is possible. Then the teacher is also happy, child is also happy. Actually, child usually has less than 1/3 of 60 to 80 visual processing functions. Every child with CVA has their own unique pattern of vision. Every single component is affected in different proportions and different degrees in every single child, like a kaleidoscope. Our aim is to find and know the limits, and staying within them using alternatives extend the limits. The approach is a transdisciplinary one. Then first thing is whether the diagnosis of CVI, then any ocular problem is associated with CVI, then that should be dealt with, like cataract or strabismus or refractive errors. Then counseling. Counseling is a very important part, because you should tell the parent that only if you know how your child see, you will be able to help the child by arranging required environment. And another thing is, you can give a concept about neuroplasticity also, like the neurons fire together will wire together. This is a history. For history, we do taken this Dutton's inventory and translated to Malayalam. Evaluation part is in visual acuity, refraction and dynamic retinoscopy all should be done in this CVA clinic. Okay, this is dynamic retinoscopy. Video previous. See, this child, when we visited a blind school for a camp, from there we picked up this child. Actually, he's some 10 or 11-year-old child. He had autistic features also. See, he's a case of Balin syndrome with optic ataxia, simultanagnosia, and dorsal stream dysfunction. When we assessed, we could make out that accommodation lag is present. So we gave a +3 glasses. See how he is managing now. He's seeing this. This is another girl with spastic diplegia. It was very difficult to assess this girl, but with great difficulty we could do the refraction, and it was -8, and that is why she was streaming. And after giving correction, she's very happy. So the moral is, the most cost-effective intervention in CVA is spectacle correction. The functional vision assessment, most part is dealt by Dr. Sujata, Leah Gratings, Hiding Heidi, then visual field assessment. All these should be tested. And Leah puzzles for cognitive function. Now, in low functioning, very low functioning CVA, where the child cannot even have visual awareness, then you have to keep the child in a monochromatic translucent tent to eliminate the surrounding clutter. Then enhance the attentional capacity and enable him to utilize the limited vision, and show a illuminated toy in dark room with auditory or tactile elements. Because when the vision is weak, you should have both the other parameters to have a strong, memorable response. That is multimodal stimulation. Then light pad activities. So coming to the visual intervention, what we are doing is, it's not a passive one. It's an interactive approach. Instructor chooses specific stimuli, making adjustments in assessment while looking at the reaction of the child. And this should be carried out within the context of major developmental activities. First thing is helping the child to use the vision, and secondly, helping the child to understand what is seen. Then strategies are like when lack of vision on one side, you can have you can make the child to sit on one side of the classroom and rotate the plate to see the food and all. Lower field assessments, impairment, then you can keep the floor clutter free, and you can use white shoes, like that. Depending on the problem, you can have the strategies. And it's always teach the child to be, it's okay to be different, atypical. The three key rights for children with CVA is right to learn, right to independence, and right to effective social interaction. CVA can be very disabling but trainable. With right training at the right time, their skills can be enhanced. This is a success story. A profound CVA girl who was diagnosed at 9 months with congenital ESO. She was operated by Dr. Sanita, and now she's almost normal, going to school. At this juncture, I would like to extend my sincere gratitude to my mentors, Dr. Gordon Dutton and Leah Highwarner.
Thank you, Dr. Geetha, for the